So I'm going to talk about cardiac rhythm disturbances in training and racing in the UK to try and sort of bring us back closer to home. And we all know that the horse is a unique athlete. One of the reasons for why that is its ability to go from a resting heart rate of around 25 to 30 right up to galloping heart rates in excess of 220. The stroke volume, the amount of blood that's ejected during each heartbeat, doesn't actually change massively, but superior athletes, Laura alluded to this work, it's been shown that particularly in national hunt racing and steeplechasers, the bigger the heart, the more successful the horse. So thoroughbreds as a breed have larger hearts than other breeds, and elite thoroughbred athletes tend to have larger hearts. But that stroke volume doesn't actually change that much. So most of the change in cardiac output, which is the meaningful change, is due to that change in heart rate. And expanding on what Laura has already described, in order to achieve or in order to be able to sustain that heart rate, the heart has to, the pulmonary circulation has to operate at very high pressures. And that is one of the reasons why that if something goes wrong, very quickly the high pulmonary artery pressure there that is there in every horse can spill over into quite dramatic hemorrhage into the lung, which might be seen by a pathologist, or indeed out of the nose. So I just thought it might be worth giving you a quick refresher of ECGs, so we're all on the same page, and particularly for those of you who didn't go to vet school. The cardiac electrical, or the mechanical vents, the pumping of the heart, is triggered by electrical events, and it's critical that that happens in a coordinated fashion. And that's because the heart has to be given time to relax and fill in order that then it can empty effectively. And ECGs can appear to be quite daunting and alien, but if you think of them as being a roadmap, they're basically mapping how the electricity is moving through the heart. The way that the cardiac cells achieve that is by having electrolytes move in and out of the cells through specialized proteins which are known as ion channels. And we'll, when Kamlan talks, and I think Laura already alluded to, when we talk about channelopathies, what we mean is something going wrong at the level of these proteins that are allowing electrolytes to move in and out. So going back to this roadmap concept, the electrical signal begins in the sinoatrial node and spreads out through the atria, and that's represented by the P wave. It then hits the AV node, where it has to pause for a second to allow the atria to empty, the ventricles to fill and get ready to contract themselves. The ventricles, the main pumping chambers, are then triggered by the QRS complex. There's then a refractory period where essentially the potential electrical difference across the cell membrane has to reorganize itself. And finally, there's a depolarization, and after that depolarization, and only after that depolarization, the cells are ready to do it all over again. So as I say, it's helpful, I think, to just view the ECG as a way of showing or documenting how the signal is moving through the heart. And reasons for why equine athletes are prone to rhythm disturbances have been expanded upon already by Laura, but I've just summarized them here, and just to maybe pick out one or two of the things that Laura didn't mention. We know from some work done in standardbreds that psychological factors, in other words, excitement, and that can be excitement in a positive way or indeed in a negative way, fear, can have a contributing factor. Laura talked a bit about the remodeling and fibrosis scar tissue that can form within the heart. But one of the interesting things is that we tend to see these arrhythmias as the heart rate is slowing down, and that is at that phase immediately after exercise or after peak exercise, the heart is receiving conflicting signals with the nervous system telling it to slow down, but the adrenaline and other catecholamines that have been released are still there, and they're telling it to speed up. So it's quite a vulnerable period. We're beginning to learn more about some of the conditions that occur in human athletes, so channelopathies, Laura has discussed. We also know there's a lot of interest nowadays in congenital accessory pathways, and these are basically, there are fibers moving through the heart which carry this conduction, and foals can be born with congenital abnormalities, so usually extra fibers, and these are known as accessory pathways, and they basically allow the signal to go in the wrong direction. So I've taken these diagrams from human medicine, but the abnormal tissue is the green tissue. So the wave of depolarization should always spread forwards, but if you've got a little extra pathway, you can have a situation where it's looping around and going in the wrong direction. And these are some ECGs from a case that we diagnosed recently in a 2-year-old filly with a very variable performance history, where we were able to show that she had an accessory pathway. So that's an important potential cause from human medicine. So the recording, I'll shut up in a moment so you can hear it, but the recording is an example of a premature depolarization. You heard it there. Now, so when we listen, we may hear the premature depolarization, and it's illustrated on the tachogram right here. But of course, just hearing it doesn't allow us to figure out where it's coming from. Now, traditional classical cardiology, it's always emphasized that you must work out if it's coming from a supraventricular location or a ventricular location. And we do that by looking at the ECG. So there's the normal ECG. And when you have something coming from the atria, it's going to have a P wave that's a bit different, and it's going to come early. But once it gets back on the road, as it were, goes through the AV node, it'll have the normal QRS configuration. Whereas if you have a ventricular complex, then it's going to have a completely different shape. And the reason why that's considered very important in classical cardiology is that ventricular rhythms are considered to be much more unstable, much more likely to cause sudden death than supraventricular rhythms. However, there are some problems, and we have to recognize that when we're doing exercising ECGs, we're looking with a very simple lead system. So for sure, if you can see a clearly abnormal QRS complex, you can be reasonably confident that that's coming from the ventricle. But it doesn't work the other way. So some QRS complexes can look as though they're coming from a supraventricular location and indeed be from a ventricular location. So it's often considered better, rather than being very definitive about whether it is or is not ventricular, it's better probably just to describe what you can see and avoid over-interpreting the ECG. So how common are these rhythms? We know there's been a lot of work done in standardbreds, and in standardbreds, they have been able to record ECGs during racing, which is yet to be achieved in thoroughbreds. And this is where the work showing that they, one, are very common in the immediate recovery period, so as the heart rate is slowing down. And there's also some results there that would suggest that psychology is coming into it. We've looked at apparently healthy horses, so just random 2- and 3-year-olds, put an ECG on them. How often did we find arrhythmias? We looked at 105 of them back in the days when I didn't realize that we weren't supposed to describe them as ventricular and supraventricular, and I haven't bothered to make a new graph. But What I would point out here is they're common at all phases except during exercise, but they do occur during exercise. And here I'm talking about individual premature depolarization, single isolated extra beats, which are not actually going to affect the cardiac output much, and they're not going to make the horse feel ill or tired or anything. We've also looked at rhythm disturbances following racing, and so this work was done by a team from Nottingham University, where we looked at 590 horses on 6 tracks within 15 minutes of finishing, and using AliveCore phone devices. And I'll come back to atrial fibrillation later, but if we just stick on the isolated premature complexes, you can see 6% of these just shy of 600 horses had arrhythmias, sorry, isolated prematures. When we look at horses that are presenting for poor performance, there are a bunch of papers on this, but I highlight this one because it's UK based. So this is data from my own clinical population and coupled with the team at the University of Bristol. So together we looked at 245 horses, just over half of them were national hunts. And essentially what we're looking for, we wanted good quality ECGs and dynamic endoscopy. And I think I'd point out that the important messages here. Only about a third of them actually managed to achieve their exercise evaluation without having any form of arrhythmia. 45% of them had isolated prematures, and roughly 20% of them had more complex rhythm disturbances. There was a link with dynamic airway obstruction, but I'll just throw that out there and leave it because I don't really have time to expand upon it. And then looking at what happened to these horses, the majority of them did go back to race training. So obviously one of the goals was to try and find out, can we characterize, are there clues on the ECG that this horse is going to do badly versus the other ones who are going to do okay? And clearly, having listened to all the work that was described this morning, I realize in cardiology we are the poor cousins. You know, we're just beginning on this road. But for what it's worth, looking at the horses that had what were defined as major complex rhythm disturbances during these ECGs, the majority of them did go back racing, and many of them raced successfully. And when you look at the ECGs, there aren't really any good clues as to which are going to do fine and which are not. So if you look at the different definitions of variations on different types of arrhythmias, no real clues there. However, I kind of feel like maybe it's to do with the duration. So the typical short run of ventricular tachycardia is illustrated here. That's going on for about 2 to 3 seconds immediately after the horse pulls up. The horse is probably not really going to sense that. It's not going to, and clearly it's pulled up, so it's not going to impact on its performance. Whereas this example is from a case that had a duration of arrhythmia for well over a minute, and this horse had much more dramatic clinical presentation. I can tell you it was a consistent finding. Essentially in that entire strip there is not a single normal heartbeat, and that went on for a total of 1 minute. It's actually this guy here. Where is he? It's this one there, that's the yellow one. Because of the significance of this arrhythmia, it was decided that it wasn't appropriate to continue to train this horse, and in fact it was subjected to post-mortem examination, nothing to see, no structural changes, and I think that highlights the challenge that Laura has already identified. Laura's talked already about this study, so I won't expand upon it terribly much, other than just to point out that, you know, we talked all this morning about horse safety, but it is, of course, important to be mindful that jockey safety is an important consideration with catastrophic musculoskeletal injuries. And in terms of frequency, obviously, because there are more musculoskeletal injuries, the more jockeys will be injured. But nevertheless, in this study, which comes from California, if jockeys were more likely to be injured if it was a sudden death than a catastrophic fracture, which I think probably does make sense. And it's this background, there's always, in cardiology, there's always this, we operate in this world where we're not only thinking about the horse, but also about the jockey. And I don't really know why that is, why there's a difference between internal medicine people and surgeons. Perhaps Chris might be able to explain that to me, but nevertheless, there is a lot of fear around cardiac arrhythmias because of this. But I also learned very early in my career that if you pronounce that a horse is unsafe to ride, then that is a very life-threatening situation for that horse. So when we look back at our poor performance horses, actually didn't seem to matter. Indeed, one might argue that the ones that had the complex arrhythmias were rather better off than all the others. But there, certainly as a group, the horses that had the arrhythmias had similar proportion returning to racing, similar number of races run, which suggests that for a lot of these arrhythmias that we can pick up, it's actually not a contributor for sudden death. And I think that's the challenge that we have yet to address, is that we really don't have a good way of separating arrhythmias in general from that subgroup that are likely to have a poor outcome. So if I move on now to equine atrial fibrillation, this is the commonest cardiovascular cause of poor performance and exercise intolerance, characterized by an irregular rhythm. This little video, which I've clearly stolen from the internet, illustrates what's sort of going on in electrical terms. So we've got random electrical activity circulating around the atria. Every now and again it's going to hit the ventricles, and the ventricles will contract, but they do so in an irregular rhythm. Now, if this becomes sustained, as Laura already alluded to, it's going to need treatment to get it back to normal rhythm. But in fact, paroxysmal, i.e. self-curing atrial fibrillation, while it's not quite so well recognized and written about in textbooks, is actually much more common in racing thoroughbreds than sustained atrial fibrillation. So this is what it sounds like. So just a chaotic rhythm beating every now and again. So some statistics. The first early work on this was done actually in Japan. There's been studies done in North America in standardbreds, and then in the work that Imogen Common did, the Nottingham study I alluded to, various different prevalences, depending really on how they looked for it. But it actually was established in the Japanese study that I think in their study they had about 98 horses and only 2 of them needed treatment. So approximately, or indeed above, 80% of exercise-associated atrial fibrillation will self-correct. And that's what you can see happening here with no treatment. The horse is just standing in a stable, wearing a monitor, comes in with atrial fibrillation, decides, after all, that it doesn't want to have atrial fibrillation, and it corrects again. This is the group that Simon is describing. So a typical history would be, it depends exactly when it occurs. So if it's exercising when it occurs, then you can have quite dramatic fading. You may have nosebleeds, as illustrated here. When you get to listening to the horse, you're going to hear that tachycardia and irregular rhythm, and often extremely high heart rates initially. Takes a while for the horse to recover. But it's important to bear in mind, and I think that this is probably what happened in our racing study, because of those 2 cases that were identified, neither of them had particularly dramatic poor performance on that occasion. It can happen after the peak exercise, in which case there may be relatively minimal signs, and we also know from looking, or we're starting to look at data from the equimeter and what have you, that if the exercise session is not particularly intense, then the signs may not be all that dramatic. But since we've been talking a lot throughout this session, or the whole day, about life-threatening catastrophes, did just want to make the the point which reiterates what Laura has just told us. We should be thinking about atrial fibrillation more as a performance-threatening condition rather than a life-threatening condition. It's not entirely true to say there is no link, but the vast majority, the really vast majority of horses with atrial fibrillation do not keel over and die. Here's an example of the collection of the two-phone system of diagnosing atrial fibrillation. So what do we know about it? Well, actually, most of the recent work has indeed been done by Laura, and she, working with the group in Hong Kong, has produced some nice longitudinal studies showing that it's a recurrent condition. And I think the thing is, what I would contend is that we probably miss a lot of episodes. So when we talk about the chance of recurrence, whether that, I think Laura quoted 20%, I would previously have said about 5% chance of recurrence. Those are occurrence of episodes that are detected. But again, the more you look, the more you'll find if you put monitors on these horses, they can be having clinically silent episodes. So here's an example of a horse that had recent PAF, and that represents probably about 18 seconds of atrial fibrillation that's just standing in its stable, fibrillating for 18 seconds, back to normal rhythm. So what do we know about PAF in the UK? It certainly is timely to do some epidemiology that will hopefully help race vets and others in this country. So the Horse Race Betting Levy Board has generously funded a study which I'm involved in, Cameron's involved with, as is James and Sally, who are here. Broadly speaking, we have two arms. We're going to look retrospectively at data from the race courses to identify prevalence, risk factors, and what have you. And then we've got a prospective arm. Now, when I decided I was going to give this presentation, I was confident I would have a huge, robust set of results to share with you, because we'd be starting this work in October. We're actually going to start most of the work in August, so I haven't got as much to share with you as I had hoped. But what I can tell you is, looking back on the BHA database, we identified 313 horses, so just some broad statistics from that. Prevalence, and I've expressed this in terms of per 10,000 starts, unsurprisingly more likely to happen in jump racing than flat. But an interesting observation here is that if you multiply up the 600 horses in the Nottingham study, it's another example of, if you look, you will find we were surveying every horse and found much more of it. Whereas obviously these horses from the BHA database are those that have been flagged as having poor performance, and also probably also not listened to quite as quickly as we did in the Nottingham study. James at lunchtime shared with me that in their when they've reviewed their pre-race findings, multiplying it up, I think, to one, it multiplies up to about 10 in 10,000. So horses are arriving at the racetrack with atrial fibrillation. In terms of our prospective arm, Camelan's going to expand upon that, but what we're going to do with these. But so far we've logged 14 horses, one of which has been recurrent. So in terms of a diagnostic plan, if we identify these problems, I would advocate quite a comprehensive cardiac workup. So echocardiography, biochemistry. I think it's very important to do a decent amount of resting ECG, because I think one of the groups that I would emphasize is if it's got an arrhythmia at rest and exercise, that is more significant than a horse that just has exercise. Because I think a lot of referring vets who I would deal with focus on the exercise ECG, but I think the resting ECG is just as important. So for our study, we're actually not doing such a comprehensive exam. We're only really recording an exercise ECG plus about an hour at rest. And this kind of highlights the caveat. So what we're collecting for our study should not be regarded as a complete workup. And of course, within days of starting the study, I realized the flaw in this plan. So here's the horse that's had recurrent AF. He had initial ECG as requested, maybe not quite the hour of rest that I'd asked for, judged to be normal. fibrillated a couple of weeks later, or 3 or 4 weeks later. This time a full workup was done, and indeed it was the resting ECG and the echocardiography actually that was much more illuminating than just the exercise ECG. So here I've just put a star indicating the supraventricular premature depolarization that was easy to find when you had 24 hours of ECG to look at, not quite so easy to find when we only had a short period. So there are lots of devices out there that has really changed the landscape in equine cardiology, made it much easier to identify arrhythmias. The one I like is, of course, the most expensive one, the echo, which combines ECG and audio recordings of the sound. But there are several devices. Laura mentioned the equimeter. That is undoubtedly the easiest device for trainers to use. It gives you a lot of data about speed and sectionals and so forth, but also gives you a heart rate plot. And from that, you can extract an ECG. So we haven't done very much work with the equimeter yet, but just to illustrate, this is a case actually that came in only last week, where it was the unusual equimeter trace that prompted the trainer to seek veterinary advice. So I hope that you can see this. Perhaps if I show you, this is what it should look like. A nice sort of heart rate goes up, heart rate goes down. In the middle panel, you can see the heart rate goes all over the place. And the ECGs are not that easy to read, but they do show atrial fibrillation. And you can also extract what things called Poincare plots, which is very different in the horse with atrial fibrillation. You get this wide triangular base as opposed to the nice straight line. So I think now we have the equimeter. It gives a great opportunity. We could think about recording ECGs during racing, and again, going back to the team at Nottingham, we did some work trying to develop an ECG system that would embed in a race cloth. I know I'm going over time and there's no one here to stop me, so I'll just tell you, basically we tried and it didn't work. And there's another challenge. If we start recording loads and loads and loads of ECGs, which indeed is happening with the echometer, who's going to look at all these ECGs? So I say that really as a segue into the next presentation, where Cameron will describe to us how artificial intelligence can help us in this respect. But to summarize, exercise-associated rhythm disturbances are common, particularly as the heart rate is changing, transitioning downwards. The prevalence, the exact prevalence, varies primarily on the method of detection and also the timing. And at this point in time, it remains quite difficult to determine their clinical significance. So we're a long way behind the people who are interested in musculoskeletal catastrophes. We do know, however, that paroxysmal atrial fibrillation is the most common form of impactful arrhythmia. And if it's not characterized immediately, then it can be very difficult because the horse quickly goes into sinus rhythm and then it's gone. You can't find it anymore. Exercise-associated rhythm disturbances do have a role in exercise-associated fatalities, but untangling that, certainly predicting that, is impossible at the moment. However, we're kind of in a good place because the future looks positive. We've got the wearables. There are developments going on in artificial intelligence, genomics, transcriptomics. So I think if I was giving this presentation in 10 years' time, it will be very, very different. And for the vets that are out here in the audience, I will certainly be telling you more about this, but we will be very grateful if you could help with our ongoing studies. I think I'll stop there and thank you for your attention.